Hello, my name is Benjamin Dome, and it's my pleasure to present today on labral reconstruction made easy for an evolving technique update. As Thomas Edison said, I have not failed, I've just found 10,000 ways that won't work. And I will try to share those ways with you so that they do not have to be repeated, and rather you can choose an easier path. So the anatomy and purpose, the labrum increases hip stability. It increases the articular surface by 22% and the acetabular volume by 33%. It creates a sealing effect that maintains the articular fluid film, and it prevents lateral displacement and distraction forces. It also plays a role in load bearing. So overall, it's a chondroprotective structure, and that's what we're aiming to restore. So when do we take the leap for a labral reconstruction? Well, our indications in the primary setting may include insufficient labral tissue or segmental loss of the labrum, or a calcified labrum or severe labral intersubstance damage. In the revision setting, they may include failed debridement or failed previous repair. Labral reconstruction has been defined in a consensus study, which we published in the Journal of Hip Preservation Surgery, as a very difficult surgery. This was a cross-sectional surgery based on high-volume hip arthroscopists, all of whom agreed that this was a difficult surgery and one that ought to be undertaken in high-volume centers. So the question of when to reconstruct the labrum and how much labrum to reconstruct really comes down to what is viable labrum. On the left, you see a shredded labrum. On the right, you see a calcified labrum. These are not viable labra. They cannot be repaired in any effective way that will restore the suction seal. So this is our algorithm devised at American Hip Institute on treatment of a labral tear, wherein we defined that if a labral tear is repairable, we repair it. If it is irreparable and there is a segmental defect with a preserved chondrolabral junction, then we may augment it. If there is a compromised chondrolabral junction, we may perform a segmental reconstruction. And if there's a complete defect or disease of the entirety of the labrum, then we'll perform a circumferential labral reconstruction. So stop right there. Contraindications to labral reconstruction may include narrow joint space, arthritis, tonus, 2 or more, any significant femoral head cartilage damage, or any extensive cartilage damage on the acetabular side. We have to choose our grafts. A variety of graft choices have been put forth in the literature, including allografts, such as TFL, semitendinosus, iliotibial band, anterior tibialis, posterior tibialis, or dermal allografts, as well as autografts, including rectus femoris, gracilis, IT band, and dermal tissue. And probably any and all of these can be effective grafts. We have looked at a consensus study on graft choice and found that a variety of different grafts are chosen by experts. And we've also examined the outcomes and found that no differences were found in clinical outcomes between hamstring allograft and autograft. Furthermore, we have looked at these outcomes at minimum 5-year follow-up and found similar satisfaction with allograft versus autograft and comparable MCID and pass rates and improvement in PROs. So labral reconstruction itself as a procedure can be a confusing procedure. There can be a lot of difficult steps, and we want to try to make these things simple. And that's where we bring in the knotless pull-through technique for labral reconstruction, as we published in Arthroscopy Techniques. Labral reconstruction using the knotless pull-through technique. So this technique applies for segmental or circumferential reconstruction. It requires no more measuring. We do not need to measure the length of the defect, which is fraught with error. And here is the technique. We first prepare the rim, then we place the knotless anchors. Here you see a revision case with a diseased labrum from previous repair. We remove that. We place all the knotless anchors along the acetabular rim, and then we insert the tendon graft. You see the anchors are placed throughout. The tendon graft is inserted. It is pulled through the joint out the posterolateral portal, and then it is fixated with the pre-placed anchors working from anterior to posterior. So we work our way around the horn here, one anchor at a time, using the knotless tensionable anchors. We can do this in a pass and cinch, pass and cinch, pass and cinch technique. And here's the completed reconstruction, looking all the way from anteriorly around circumferentially to posteriorly in this case, where we have a circumferential labral reconstruction. When we take traction off, we see good seal of the labral graft against the femoral head, and there's the anastomosis between the graft and the native labrum. So the money shot is when we take traction off, release traction, and confirm the seal against the femoral head. In case you were wondering what happens after this heals, we have fortunately only had a handful of second looks after labral reconstructions, but here is one where we see fully incorporated chondrolabral transition, a fully incorporated anterior and posterior anastomosis, where it's in fact hard to tell where native labrum stops and graft begins because it is so well healed and so well incorporated. Minimum 5-year outcomes were published by our group in this journal, in the American Journal of Sports Medicine here, showing comparable functional outcomes when compared to a benchmark repair group. Reconstruction has given us the possibility of doing augmentation using the same technique to preserve what is left of the native labrum and augment it with a graft. And this can also be done with the knotless pull-through technique, preserving circumferential labral fibers, potentially better sustaining hoop stresses and offering a better seal with the same technique when possible. On the left, you see some labral remnant. On the right, we've preserved that labral remnant and rolled it together with a labral graft to make for a labral augmentation. So in summary, I ask not for lighter burdens, but for broader shoulders. These are difficult cases, complex cases, and they require a broader range of techniques in our armamentarium to handle. And those complex techniques can make use of technology. It is helpful to know what's in your quiver, and that may include labral repair, labral reconstruction, both segmental and circumferential, and labral augmentation. Choose your cases wisely, consider additional training. These are complex techniques, and I wish you all the best of luck. Thank you.